so you don't use the gel. So we use the gel pads. Because the gel pads, once
We use the gel, we put it on the...
No, I know. I've used that one. I'm from that generation. Okay. But it's basically, it's now, it's just because of the risk of electric concussions to this, fusion for this, it's basically not recommended, so it's out of fashion. It's mainly in developing countries, they use it. We will say developing countries. Basically in Western Europe or in Europe generally, we have the machine, we connect these ones. The advantage of this one is, first, once you connect it, you minimize just disruptions. But in your situations, we accept that it's okay. So,
so doctor, it's ideally allowed to connect those onto the...
yeah. So what we will do is, it comes, probably in the future this might change anyway. So they are a bit more expensive, and that's why the reason they are not available here. This is more reusable, it's one time. There is no infection control type of things with this one. So essentially, you use it on this person, so you can use it on another person, and there is a risk of basically transmission of infection if it's not been cleaned properly.
It's also designed for pediatrics.
Yeah, so there are smaller size for pediatrics. And obviously this is an adult size. Today we are not covering pediatrics. Yes, you can change it, yeah. So what I'm saying is, moving back to here, you can see the picture of this. Okay, you can see the probe. So one of them is go on this side of the chest, and the other one's on the left side of the chest. You don't need to be precise. The whole thing's when you apply the pads, what do you deliver? Electricity. Okay. So there is electricity from one positive side to go to the negative side. So the electricity transmits from this side to the other side. So it has to go through a pathway. Okay. So what we call it impedance, resistance. So the tissue, it has a resistance. Okay. So when the resistance of the tissue is high, or if there is contraindication, you put the pads in. If someone has got a pacemaker in here, or if there's like an injury or trauma, or a type of wound, you can't put it, then we can put it into your posterior. So you can change it. Even with this one, you can do the same principle. Yeah?
Anterior posterior?
Yeah, back and front. Yeah. What would you do if you couldn't put, if someone is burned completely?
How could we keep the patient sideways without touching him?
Exactly. Sometimes in situations. Exactly. But these are extreme situations. But what I'm saying is, with this one, it's far more advantage with this one. With this one, that's why it's not anymore of use, because with this one, when you apply it, and then you move your hands off, it's already connected, and it's checking the rhythm for you straight away.
I'm sorry, just one more point. This is the one in the apex should be in front, and the other one in the back, right?
Yeah. This one's going to be in the front. This one's going to be in the back.
The apex.
Yeah. This one's good. Is the main thing is the electricity from here to the back.
Front to back.
Yeah.
It has a pathway.
Yeah. Okay. So that's the thing. Right. So so the main thing what we will do is to do it safely. The whole about the station, how we deliver the shock safely. What's the danger of this? Of who?
To the bystanders.
Bystanders, and who else? Yourself.
Yeah.
You could be touching the bed, and if there is no enough conduction of this one here, the electricity might go through any connection of the hand of the patient attaching a metal there. That electricity will go, and it's basically electrocute yourself. And it's 360 joules is a massive amount. 150 is a lot by FASIC. 250 it's 360, that's what we do, is a lot. And that's why the safety aspect of cardiovascular is very important. So, you all use this machine. Did you say some of you have used it?
Yeah.
Yes.
You have used it? Yes. Okay. So, if I tell you how we're going to take me through the steps.
Okay, so we have a different model, but first I turn it to the monitor side. So first to check within. If it's shockable within, then
so you will have a dial.
A dial, yes.
Okay. So you have a dial on the side of the machine.
The first step is monitor.
Monitor. Let me just. Yeah. Okay. So you got the one that it has a dial. So we probably have a machine in here that it has a dial in. Okay, so you put it on the monitor dialing side.
Yes, on the monitor mode, and I check for rhythm. If it's shockable, then I change the dial to the joules.
Yeah.
It starts with 150.
So suppose that this is a patient, he's in arrest, okay?
Yes.
You got Kaka Hammer, he's there. Someone is doing a chest compression, and I'll give you a scenario. Someone's doing a chest compression, you're in charge of that defibrillator. Do you understand what I mean? That's what the aim is. So if you are in a situation where there is a bit of manpower, when you have more like a team like I showed you in the picture, then what you need to do is you allocate someone to do this for you. You don't think about he's delivered the wrong joule, he's assessing the safety of the thing. Do you understand? If you're going to be the person who's delivering that one, you need to basically be able to what? Deliver it safely. Exactly. So, talk me through it. Kakahme is in arrest, you applying the pads on, what do you do?
So I start the monitor on the monitor mode,
Yeah.
I apply the pads,
Yeah.
and I check the rhythm.
Okay, so
So according to the rhythm,
what type of rhythm?
so we have shockable rhythm, which
What is a shockable rhythm?
VF, ventricular fibrillation,
Yeah.
and pulseless VT.
Good.
And non-shockable, it's systole and pulseless.
Good. So if you have a shockable rhythm,
Shockable rhythm.
so what do you say? What do you do?
So I'm going to shock this patient. I'm going to charge.
Good. So you'll say, actually, it's a shockable rhythm.
Yes.
You have to
Everyone
announce
stop.
to the team. You have to tell the team. You have to tell the team that I'm gonna.
So basically, what's happened when you check the rhythm, that person stops. Who's doing the chest compression? Let's check the rhythm. It should take less than 5 seconds. That's the main thing, is to minimize the chest compression. Okay.
But when it's a shockable rhythm, I'd say continue CPR while I charge the.
Good. So you go back on the chest, and what do you do?
I charge it to 150.
Good. Show me how you do it.
Okay, so I'm just getting to know this.
Yep. You use the use the gray. Yep.
Okay, manual mode. So this is 200 joules,
Yep.
no sync.
The yellow is always charging.
So this is 150. But
No,
Yeah.
that's delivering the shoe. Direct. The yellow is charging.
Okay. Good. So the reason I wanted you to do it, because I wanted to see how some of you are familiar, and that's why I'm saying is when you go to your hospital, really need to familiarize yourself, because in a situation like this, you don't have time to think about it. It took me some time to figure out how I charge this.
yeah.
Really?
Doctor, in our practice, we take an overlap through when the newly graduate will take the hospital. And through the overlap, we will teach them to every call,
Even with that,
check
yes.
all the instruments and the devices and
That's
the
right. But how often
And
do you
the
remember?
availability of
How often do you remember that? You need to go back yourself and check it.
Yes.
So that's always what I say. You will get inductions. Any hospital I start,
That's
we
what-
get induction. So that's what we call it.
Sometimes
The overlap we call
with another
induction. So you
machine.
need to be induced about what is happening in the hospital. But then you need to go back and familiarize yourself. With this one, if I go to menu, yeah. So I'm trying to go to the menu. There we go. There we go. And then to semi-automatic mode.
No, the automatic manual.
Select. Share.
Go to the manual. Then track.
It should. I did it this way. It doesn't
You
do
will
it.
select the power.
We said the power is selected. Look.
Okay, now select.
It says
Okay.
push paddle to charge.
Push paddle to charge. Push paddle to charge.
I'm going to disconnect that one here. Because sometimes it doesn't do it because of. Let's see, that's the VEF.
Yes, now charge.
Okay. اتوانين ربطي كم بكهرباء بو؟ No, no, ربطي كم بكهرباء مشكلة. It doesn't do it that way, I know.
Usually you have a yellow button here.
I know, the yellow button doesn't do it that way. Analyze. And
It's charging.
it's charging, you see?
Shock advised.
Yeah, and then
Stand
you
clear.
press that one, and then you,
And deliver it.
yeah.
And it should be away.
So that's what you do, and the impedance is done it. And this is the machine. It took me some time to figure it out, but essentially that's what you do with this machine. Okay, but in your machine, in the one that is actually provided in most of hospital, it has a dial. So you put it on monitor, and you check the rhythm. Once you assess that is the shockable, non-shockable rhythm, you're going to say it's actually shockable rhythm. Go back on the chest. Yeah.
Yes, until
Okay.
I complete
And then
the charge
we
and set. and
charging.
then- Yeah.
Okay.
Once it's charged, I'll say everyone clear, disconnect oxygen,
Okay.
and then
So-
I'll deliver the charge.
Good. So what I want you to do now, I want you to show me the correct way of conversion. Good. Yeah. So suppose this is the patient, and this is Kaka Hamma. He's in cardiac arrest. Okay? We know that he's in cardiac arrest. Now you told you Kag Ali. Kag Ali is doing chest compression. Chest compression Kag Ali.
Okay. And we'll do by two hands on the
Yep.
center of the chest.
Good.
And you straight your elbow.
Yep.
And by your weight of the trunk.
Vika, just do it. Good. So he's doing cardiac arrest. He's doing the chest compression. I'm the team leader. You're in charge of it.
Okay. On defect.
Yeah. What is the best way to do cardioversion? Where do you need to be on
Right side.
which side of the patient? Or to be by the side of the patient,
Yeah.
not to be on the top end. Why don't you go on that side? Make yourself, in control.
So this is the apex.
Yeah.
This is the sternum.
Good.
I'd say, please, Ali, stop compressions.
Okay.
I'm gonna check the rhythm.
And this is the rhythm.
1, 2. This is the rhythm. This is actually it's switching to fine rhythm. So it's assistole.
Is it? Is what did we say if it's
Let's check the pulse.
It's-
Sounds well.
varied amplitude, bizarre waves? It can be coarse or can be fine.
Yes.
VF. Okay, is not a flat line.
Sometimes you don't get a straight line. So
Yeah, it's not a straight line, but it's not a flat line.
okay.
Okay.
So this is fine VF.
Okay.
So this is shockable rhythm. Please, Kak Ali, continue CPR.
I ask you to do the chest compression, not the airway. Sorry.
Continue CPR.
Yeah.
I'm going to charge.
Continue doing CPR.
Okay.
So you're doing CPR until he get himself set up for the charging. So why you synced it?
No sync.
Put sync.
No sync. Yes.
Okay. Okay. It's not
It's charging.
Good.
So it's
Okay.
So it's charged. Please, everyone clear. Disconnect oxygen.
You need to say everyone clear because you need to look all the way around, have a nice scoop around because there might be people. Okay? Good.
I delivered. Please continue CPR.
Good. That's why I wanted to do it. Excellent.
Not check again.
And then how long we continue for?
A full cycle, 2 minutes.
Okay.
And then we check again. We
Okay.
check
And when do we give adrenaline?
adrenaline after 3 shocks.
The third cycle. In the third cycle. Yes. In the third cycle. Good. Cool.
Now I'll count loudly for 30 compressions. And
I just basically, I usually do this way. And you put an and in between, and it will be around 100, 120. Okie doke. So that's one. Come around and do the same. So you do chest compression, someone's do the cardioversions for me. Okay? And we take turns.
Okay.
Yeah?
So
Good. So you've done that one. So I want to see your chest compression.
just at one point, for the legal issues here, we always draw to print the
Oh, right, okay.
ECG, yeah, through the whole cycle. So we need print.
It's automatically most
Yes,
of the
it's
machines.
automatically printed. Yeah.
Automatically.
That's for the records.
But anyway, when there is a team who's doing it, Usually, you always have people who are actually witnessing what is happening. The main things we tend to do is we document what we saw.
Yeah.
That's your best knowledge at that time, because you could make a wrong judgment, even on the ECG, the same as now. So it's a VF or you said it's an system. If you haven't had any, you would document it, you still need to. But then the machines will print it out for you. That's the battle.
About that point, if in doubt, we should administer shock, right?
بس بنعمل برضه
Usually CPR and treat what's until you go to the second cycle and you check again.
I'm saying, if I'm in doubt about fine VF versus asystole, is it safer to deliver a shock or is it safer not?
Safer to do CPR.
Safer to do CPR.
In the third cycle. In the third cycle.
Third cycle?
In the third cycle, when you've done the second shock, in the third cycle you deliver adrenaline in there. And when you are checking, when the 2 minutes finished, then you check the rhythm. That is as actually returned if the adrenaline has made a difference or not.
Harman, if it's in the third cycle, if there's a delay in defibrillation, adrenaline could be before the shock.
The recommendation is in the third cycle. So you do one cycle, check, yeah? So you basically, you did one cycle, 2 minute, check, and it's shockable or non-shockable. It's a shockable rhythm. You go back, you deliver a shock, and you go back and chest compression for 2 minutes. And then on the third cycle, when you finish the 2 minute, you check and it's still VF, then you deliver the adrenaline at that time.
Doctor, let's assume it's after the third shock, the patient shifts from from shockable to non-shockable.
Then
we try CPR again.
Then you go back to the non-shockable side of the rhythm.
If then
you give
get
adrenaline.
back to the shockable.
Yes.
We have given amiodarone loading dose. And then
Not
get back to
enough.
shockable, let's say that the patient is shockable right now, okay? After the third cycle, amiodarone has been infused. And then he shifts to non-shockable. We try CPR, okay? And then turns back to the shockable. Shall we give another bolus of amiodarone or is it the
So
last
you
one?
just follow the algorithm. The algorithm is very clear. Why do you want to confuse yourself? So it's a shockable rhythm. So let me just mute that one first. Okay. So if it's a shockable, you will give adrenaline in the third cycle. Yeah? In the third cycle. If it's a non-shockable, you deliver adrenaline straight away. When you recognize it, you start chest compression and someone's giving adrenaline while you're doing the chest compression, you flush with a pink. And then after 2 minutes, you check. If it's a shockable, if it's become from a shockable to non-shockable side, you need to give adrenaline again if it's a shockable. Do you understand what I'm saying? If it's non-shockable and tend to shockable, then you don't give any adrenaline and you go to the third cycle from the time that is went to the shockable one.
So it's just 300 milligrams. It's just first. We can't give
300 milligram of what?
of amiodarone. I mean,
We're talking about adrenaline.
no.
Amiodarone has a long
What
time
about the
half-life.
rhythm? I mean, after the third cycle, we're gonna give amiodarone.
Yes.
That was the point of.
Yeah. So you give, if that is not responded
Yes.
to that one, then you give amiodarone, you consider it in there, and you deliver the loading dose. And then you might need to continue, once you give amiodarone, you might need to give them 24-hour dose, maintenance dose. And you can't give that peripherally, you have to put the central line. But you need, first of all, to return spontaneous circulation. You need to have return spontaneous circulation. So you give them one dose and that's it. You're not going to give more amiodarone.
So it's just one shot of.
Yeah, that's it.
Even if it's shifting.
But adrenaline, you need to give it according to the cycle.
Adrenaline has a short half-life.
Yes.
So every 5 minutes, 3 to 5 minutes, you
2
have
to
to
3
repeat.
minutes, yes.
But amiodarone has a longer half-life, so we don't need to give it every minute.
Exactly. Right. So, who's going to do the chest compression? Chest compression? Yes. Good. You come here. Who's going to do the compression?
I'll do it.
Okay. So, Kaka Hamma, he's doing a chest compression. You can see his chest compression is not effective. So you need to put your hands here. Put your hands in here. This is the center of his chest. Yeah. Good. Can you see? It's become a bit easier. And you need to lock. You need to basically lock your hands like this. And I use my counterweight. Do you know if you use too much force, you'll get tired. And you need to adjust the height. And sometimes the table is a bit high. You need to adjust the height. You might lower it down or lift it up. And sometimes people are short. they might need to use a stool to stand on. So you can see I'm using my body weight. I don't do this. You understand what I mean? So I'm just using my body weight, and I don't
Possibly you'll do it.
yeah, and you don't get as tired as you would. Yeah? Good. Carry on. And it's about 4 to 5 centimeters, which is perfectly fine. Okay, so now he's doing chest compression.
Okay.
Okay, now you are keen to help, and you say, I'm happy to use the
I can use a defibrillator.
defibrillator. Okay, now you want to check the rhythm.
Yeah, I'll have
Okay.
to check the rhythm.
Yeah.
And
So you are checking the rhythm.
yeah.
I think ventilation is missing here. Ventilation.
I know, we're just doing the chest compression and
So
Okay.
I have to apply the gel, the paddles.
Good.
And I have to tell him you have to stop and stay away.
So you try to use as less time as possible.
Okay. Now I am checking. So it's VT shockable. I have to charge it and please continue. Check for pulse.
Continue.
Yeah. Continue.
So you will tell him who's going to be the leader. There should be someone who's the leader.
Yeah.
If I'm the leader, or if she's the leader, she will say, okay, continue. You're all looking at the rhythm at the same time. So, okay, continue doing CPR for 2 minutes. Continue to do CPR while you're charging.
Yeah, I will charge
okay, so
it.
we're going to shock him.
Okay. So I have to start with 450.
The right one, actually. The right one. The right one. It's charging.
So I have charged it. Please
It's
stop.
a bit technical, isn't it?
And please take away all of you. And
Good. Well done. That's excellent. So what are you going to do after that?
I have to please continue.
CPR for how long?
For another 2 minutes.
Okay.
5 cycles.
Okay. Good.
I always tell the nurse, my nurses, whenever you see I'm off of the chest, you regain the CPR. You continue. Don't wait for me to tell you. Yeah.
Okay.
Continue.
Next one. We don't have time. We need to practice.
Yeah.
He said that it was VT
Yeah.
and delivered the shock without checking the pulse.
So basically, we checked the patient is not responsive, didn't we? Yes. Didn't we check that 10
Yes,
seconds?
we did.
Exactly.
Another point. Here we have a problem between the cycle, the term of the cycle and the set. They call every 30 compressions plus 2 breaths a cycle.
Yeah.
And every 5 cycles together, they call it a cycle, whole cycle.
Oh, right.
So when they say to the doctor, go 1 cycle, and then
No.
he confused
The
about
cycle-
it is a set or a cycle.
No, it's a cycle.
Oh,
It's a
so-
cycle. 30 to 2 is a cycle.
So the 5 cycles
Is a
together
set.
is a set.
Yes.
Yeah.
Okie dokie. Good. Very effective. And it's a very good way of losing calories. Good. So now, what's your name?
Abdul Majid.
Tag Abdul Majid. So you're going to assess the rhythm. Don't worry about this because it's very easy if when we put the pads on, we will see that ECG waves on the monitor. So these are artifacts. So anything can show.
And I'll tell her to let me check for the rhythm.
So you're checking.
And apply gel.
Yeah. So when you put the monitor, yeah, come on, go ahead. What's you could charge it?
Charging no.
Okay.
Just check. Just monitoring on the monitor and I'll check. It's VF. It's bizarre and quite complex. It's VF and it's shockable. And I will
Good.
tell her to continue CPR until I charge my device.
Good.
One of those things.
So how much you give?
150.
150 if it's a biphasic. Yeah.
And then I'll charge. And then I'll tell her to allow me.
Okay,
And
yeah.
tell the surroundings too.
Don't tell me. Do it, and I want to see how you're gonna do it.
And then tell her.
So look at yourself. Okay, this is how you do it. This is not correct way. You need to look around, give a nice look. If everyone's clear, I'm delivering a shock, and that's why we tell everyone to do it.
Everyone clear, please.
اگر تو قراری هبوی تو کس نبو این بی نرسه گوته ام شوکه لی بافیر کرد لیای کاربای لیای کارباکش بر تو که بس مو she's delivering wrong. أبي تو himki, and you have to make sure you do it in the right way. Basha, you don't want to cause trouble for yourself. So you need to make sure that everyone's clear. The better way is simply we tell everyone to do it safely, that's all. Okay, good.
And then you follow to continue CPR.
CPR for 2 minutes.
Yes.
Always.
Yes.
Good.
Doctor, which one is the apex and which one do we put on the apex?
So we can hear.
It's here. شغال تمام فيها كي؟
أنا بنتنطس كيف كم؟ أنا جيت ناكل glycemic.
بس باش قيناك عشان بتشون chest compression again.
Okay.
Do it properly. I just want to see if it's actually effective. Good. عاجز بي؟ هذا باش.
I'll check the resume.
أي مشكلة. يعني كشف. زرت. الله يتوزيله شيء بالشرف. شاطر. So when you do it as fast as possible. So there is no pulse with this.
PA, continuous PA.
Good.
And deliver.
Are you going to deliver short?
No deliver adrenaline.
Yeah. Good. Good. So you need to deliver adrenaline. But okay. So how long are you going to do? Just don't go yet. Okay.
We'll go another cycle and we'll check.
Okay. So it's now 2 minutes.
Okay, I'll check. Okay, it's PT and I'll deliver the shock.
Please help us.
So,
It's actually set.
Yes.
You just have to press the button. Yes, it's charging.
Okay, clear everyone?
أبي جاي كش عفري. You look, have a look, and then you deliver the shock. Okay. Good.
Continuous PA.
Continue CPR. For how long?
Another cycle.
How often do we check the vitals? Every 2 minutes?
Vital ET checking.
Like I need pulse
2 minutes.
every 2 minutes.
I'll do it after. Make a minute.
Is a system. شوف أما موضوعي ALS و ATLS they all been أما همي design كراو لسروي كل سرو أساسي from the same principle that when situations like this happens everyone panics. بتعبتين خوشي توبة أترسي كأمري ناخوشة. It's a very disastrous situation. So that's why from that things if you follow a system you don't forget things. And that's why if you start learning it now, when you get a bit older, it's much easier to remember. When you get a bit older like me, I tend not to remember a lot of things. So that's why I have that system in my mind. I know that is a 2 minutes, and I'll do it. But then it will give you time also to think about things. Think about reversible causes. You think about, help someone coming around or what could have happened. Okay? Good.
You're still young. You're still young. You're not that old.
يلا. Chest compression. Good.
Okay.
So Kagahama is in cardiac arrest. Dadavian? Van. Okay.
Okay. I'm Dr. Razia. I'm coming to the operation.
Yeah, sure.
Check with the
Yep. So Sadie Awaki monitor Dani. You haven't applied the pads to the patient. So you need to apply the pads on the patient to be able to see what is on the screen. What do you see on the screen? What do you think? أجر نايزاني لبرادرك وبرسبلين. هي المحاضرة كاب عشان المان. What do you think there's between the difference between shockable and non-shockable? What do you think? Is it shockable or non-shockable? لا باهين ببالته برسين. What are the shockable rhythms? Take your time. What are the shockable rhythm? Good. VF who? Pulseless VT. Wanya? VT. Again, VT پیشم VF به. And VF چیه? What is VF? What do you think is VF look like? Something like this. Bizarre QRS complexes of various implants, polymorphic. Not actually formed QRS complexes. Okay? So there is some sort of electrical activity because the ventricles are like this. Out the contraction again. Not one contraction here. We QRS here partial active. So that's a VF. Basha. If it's a VT, is the ventricle contracting? بس عزار بسريعية. So it doesn't allow time for the ventricle to refill with blood to generate cardiac output. خيني تانا شتو شو كأنه سريعة. خين فينا كخينا كبشتو نا يكسر pumpيكا. لبرو ناتوا cardiac output. تو بتشيل أوكي. أو ventricle tachycardia slow down كيتو يعني you have to shock كيت reset كيت. أما كل reset كده نوع. بس أكيد تلفزيونك يجنا ك reset ناكيتو يكوجينتو دايجرسينتو بالضبط نوع. يكوجينتو طلع كوجينتو بو literally milliseconds. So what do you do? 2? Yeah? Okay. So what do you think this rhythm? Is it shockable or not shockable? Shockable. Good. Show and shock him. How are you going to shock him now? شون شوكي شيء كن يساوي كحما خلي كامل ساعات يكب هذا كده بس اللي بيه. So that's you know it's a shockable. Yeah. شيء كي. أجريت دعاء هذا فان الله يشيبك. Continue CPR. تاتو شيء كي. تاتو كهرباء حازر كي. بكهرباء اللي بيه. ونيا. Don't charge it. How do you charge? How charge it? How do you charge the pants? هذا كان don't charge it. So أما خيته أما أفكسه. عندي لا charge لسرة. أم هذا أم charge it واني يمكن. You select the energy level. أجرو energy level لو نويت. أجرو energy level لو نويت أي قري. هاي كي بحفتها عشتا الصاص وبنجا تيجيشتي؟ Yeah? MS is 150 باشا. So now you selected the energy level. Check charge it. So when you charge, it say charging. So now استا أما كهربائية أما كاباسترة. تيجي كهرباء خزنك. تيجي كهرباء خزن كر حازر كي شيء كي deliver that amount of energy through what? Through the skin. Okay. Inja. So what do you do? What do you do?
I ask her to stop compression.
Step back. Yeah.
Yes. And I put them.
Okay. And what else do you do? What else do you
I
do?
will check around everyone.
Okay.
Yeah.
Okay. And then check it. How do you heat the piano?
But they have to ask you to.
So that's why you need to make sure that it is. Okay? Good. Good. So you deliver the shot. Check it.
I ask them to continue.
For how long?
For 2 seconds.
2?
2 minutes.
2 minutes.
Sorry,
Okay, that's fine. Put it back on. Charger.
Usually, our defibs have a sound. Charge. Wow.
Okay, that's fine. بخير وسلام. لسر الماشين هستا زربي ماشينة كان باي فيسكن the new one ones. لا هي كونا كانا همو باي monofacing is the exercise of Shasta max 360.
بس أنا challenge مثلا
Usually 150 we give by facing, we give 150. You can give 200, but the problem with them is that's it. Usually for 150 you should be effective. Yeah.
Should we increase the energy after each successive shock?
Unsuccessful.
Yeah, we started 150.
I usually go to 150 and that's it. So you give all 150, 150, 150. You have arrhythmias, like if you have SVT, sometimes the recommendation you start with 50, then you give 100, and then 150. But the higher the shock you give, the more successful they are. Cool. Tweet. توكل دوانيا. شيء ما. دوردي.
Yeah. Okay. Please keep SPR going on.
Kak davan. Kak davan show us how you do CPR. Kak Hama, he's in cardiac arrest.
Okay, Dr. Davan, just keep CPR going on. Okay.
No, تو جزایرش تبان نکرای.
زي ده اینا كام
تو
وضعيه؟
جزایر بان نکرای. بان تکین استاد. Okay. So that's good. Choneki, how many you do?
30 by 2.
30 by 2. Okay, good. And
I'll do.
yeah. Good. So that's very effective. So you do CPR. Nayi Janabe?
Ferman.
Kak Ferman.
Yeah.
Esato, this patient is in arrest. Kak Davan, he's doing chest compression. And you come to help and you want to assess the rhythm. Okay?
Okay.
Masha? Good.
I'm in the
So you
film,
need,
right?
huh?
Shall I start?
Yeah. So assess the rhythm.
Okay, Dr. Davan, just keep SPR going on, okay? I'm gonna check the monitor into the monitoring setting.
Good.
Just give it away, please. I want to check it. Wow.
Good.
It's
Excellent.
trackable. Just keep SPR going on, okay?
Excellent,
I'm
good.
gonna set it into the non-synchronized setting, and I will give about 150 joules. Okay? Let's say. Okay. So.
Charge through the paddle.
So he
then
continued,
let's say this
he's
charge.
continuing doing CPR. He's
Okay,
continuing doing
let's say
CPR.
this is charged, and then after I want to clear the air, the space. Okay, everyone shall be okay. I'm gonna give the shock. Just go away, please. Okay, it's clear, right? I'm going to give it.
Did you
That's
charge
Just
it?
Keep it. I told you that. Let's assume that I have charged it.
Why you didn't charge it?
I charged it.
Did you?
Yeah.
Show me how you charge it.
Okay.
The whole idea is to be able to familiarize yourself with the
Yeah,
instrument.
this is my first time coming to this device. Okay?
Exactly, that's why. Lots of them is first time to them. That's why I wanted to, is even for myself.
Yeah.
Okay? So how you charge the machine?
I'm gonna set it to 150.
Yeah.
And then this is charged.
It's not charging.
So this.
Carry on CPR.
Just keep CPR going, okay?
Good.
Charging, I've been in power.
Okay.
That shall be charged, okay?
Kak Ferman. So now you selected the energy level.
Yeah.
Okay?
Okay.
Now you want this machine to deliver electricity to this capacitor. Capacitor is 2-plater. كهرباء خزن نکن.
Yeah, it's storing
همون
energy.
جهازك و كهرباء کی زور با خزن نکن. تا چارجی نکی ام كهرباء خزن نکد. تيجي لهم شلونه؟
Yeah.
So there is a button on the one of them.
Yeah.
It say charge.
One is charging and one is releasing. I
Yes. So one of them you charge. You press on the
That shall
charge
be charging.
and look at that. It's charging.
It's
Now it's
charging.
making this sound. Means the machine is
It's an alarm.
alarming,
Tells that it's charged enough.
ready to
Yeah.
deliver.
Yeah.
Okay.
I'm going to tell the CPR performer
Good.
to stop, please. Okay, just stop. Everyone shall be okay. I'm gonna give it. I will check
Yeah.
myself and
Yeah.
anyone else around.
Good.
And then I will give it.
Excellent.
Okay.
Well done.
Just keep CPR going on. Okay.
Yeah. For how long?
Another set. Another set. 2 minutes.
Another cycle or
Set.
2 minutes.
Yes.
Okay.
Yeah.
Good.
Okay.
Carry on. دايما طبعا بس كده.
Each of them is placing the defibrillators in different areas of the chest. I saw some of them getting really closer to each other, and the other ones were far away from each other.
Okay, so the main thing is to say you put one in here
Okay.
and the other one's close to the nose.
Okay, so it doesn't
Because the
matter how
electricity
close
goes, yeah, exactly. The electricity goes here to there. If there is pneumothorax or air surgical emphysema, sometimes resistance, tissue resistance, and impedance. تجي أجر resistance زيادة تو مجبوري شيء you have to reduce the distance of that electricity passing through this. لبرو جاي وها مثلا في استكان مثلا الكترودك يعني داني كان يشتو داني يعني كبيس ميكر يهبو ناتواني عن الكترود اللي يا داني شوفها داني بيس ميكر أخيرا كي يكين ببادك it is doable. بس لما على حال تانية you turn the patient to the side and you do this
And Doctor, on the back, where do you put it?
between interscapular.
Interscapular space. Yeah.
عملسي بدو كسايكل رقم حسابك
32.
لا بس أجر برنامج كأنه back بكارين how do breath النهاية how do you calculate the cycles like breath mania
You continue CPR continuous
برضه
and then someone's to keep the timer because at that time you're not thinking about the area anymore. So here he's free. You can use them to write the documentation, look at the notes, keeping the time. You know what I mean? So again, you can مثلا ventilator لكن هو ولا سنس الجهاز. إيش يكون هو ببرداني دوانز بريت يعني شانز بريت أنا. So that's the way كان متعاري to the It's a temporary situation that if you get an airway stabilizer. So the main thing is CPR okay? This is a temporary thing. So how much لو حالتك you are trying to resuscitate the patient. Send blood from the heart to the brain. هنا كان chest compression every time when you do 4 or 5 centimeters. That chest wall it has elastic recoil, so it's like a bucket. So when you compress it, it will generate negative pressure in the lung, and it will take all the breath out of your chest. And when you lift your arms up, it generates negative pressure. The air goes in. So top ventilation, okay. When you support him with this one, you provide more oxygen in the lungs for the second, for every time when you do chest compression. Take it and try not. Away mozaka. Let's get two airway habu. Then you will do it continuously. That's even better because acidotic zorian to shade lactate and berzebeto, hina berzebeto. Bahin kin mal kid naked do. Hamu tan kirtan waniya? No, it's a very tricky situation. Sometimes you have to hold them with that one, or you might put the pad underneath and attach it. That's why amshta affected memo jara. We're talking about complexity of patients coming on here and open chest down here. منطقي مثلا سوتابه تيجي شلونه ناتواني هين بي هذا في بخيت السر لما هو هذا أنا باو it's much easier دوم بيكونش خمي بيونا في مجال اللي كيتو and it's more accurate.
Continuous monitoring should work out.
طبعا. إما كترانسفير patient أكين if we have unstable patient we transfer them to one side to an ITU or CT scan. And that connection again, health, agar arrestic, we already have a monitoring.
What documentation is also so category level this
Doctor, how much we can level up the energy from 150 to how much we can level it up to the patient, the shock I mean.
That's what we do. The standard is allowed in biphasic, it's 150.
150.
In monophasic, 360. I can't. I try 200.
200.